Welcome back to part 2 of the lecture on chapter 6. Sorry for the rather abrupt ending to number 1. It was about time to end, I think, but I got interrupted. So anyway, here we are back. I think I can finish this part. Let's share the screen. And we were on slide 16, so I'm going to start there. Let's enlarge it, and there we go. We pretty much had finished this. We were talking about the monosynaptic reflex, which provides automatic regulation of muscle length. And this is all under the myotactic reflex or stretch reflex, same thing. It is a monosynaptic reflex, which means it's just two neurons that are involved in the reflex. A afferent neuron, which we'll look at in a little more detail in a couple slides down, and then the efferent neuron. So it sort of into the spinal cord, make a connection, process some information, and out of the spinal cord back to the muscle. That's the what is meant by a monosynaptic reflex. Two neurons involved. Of course, there's input to the whole system, as we've been talking about the reticulospinal tracts and all that. All right, and we talked a little bit about what the stretch reflex does for us in everyday life. It does modify every single movement we make. All of our motor cortex is simply sending commands about what the target should be, but the actual amount of contractile force that needs to be applied to each and every one of the muscles involved in that movement, the agonists and the antagonists, all need to be coordinated, and that's all done at a reflex level, which is pretty amazing when you think about it. Okay, let's go to the next one. And we're going to talk about the reticular formation. I mentioned we would do that. Where is it? It's actually at the core of the brainstem, and it runs pretty much the length of the brainstem. It is, it's called the reticular formation. It's a set of interconnected nuclei that are located throughout the brainstem. They're not well defined anatomically. In other words, a lot of structures, like let's take the nucleus ambiguus or the hypoglossal nucleus. If you cut a cross section through the brain, you can clearly see the boundary of those. Say, you know, it's white matter around it, and it's some gray matter within it, and you can see the boundary. And not so true of the reticular formation. It does not have a clearly defined border. But it is, the general location is around the core of the brainstem. The neurons of the reticular formation play a crucial role in maintaining behavioral arousal and consciousness, as well as regulating muscle tone and the stretch reflex. In other words, we've been talking about muscles and movements and the stretch reflex and posture and so forth, but the reticular formation is involved in your sleep-wake cycles, consciousness and unconsciousness. The pontine area, the reticular formation, generates EPSPs and is responsible for alerting you. That becomes more active there if you are stressed and you become tense and you become super alert. And the medullary is responsible for turning the whole system down, for sleeping, for unconsciousness. If you lose the pons, but have the medullary reticular formation, you lose actually consciousness. Whereas if you have a certain kind of lesion in the medulla, in the medullary reticular formation, you can lose the capacity, which sounds almost worse to me. You can lose the capacity to sleep and maintain instead a virtual awakeness continuously, which of course you really can't do well because your brain and your body all need to rest. So that neither one is good. That one sounds worse to me. Medullary reticular formation generates a somnolent state through its own activity. When it gets active, you go to sleep, or when it gets active, you have less muscle tone and less stretch reflex. It generates IPSPs on the gamma motor neuron via the lateral reticulospinal tract. So that's kind of repetitive. You've seen that in a couple of slides now. The activity between the two areas support the sleep-wake cycle and arousal responses to external stimuli, and also the interplay between those two areas and those two tracts regulates your muscle tone and the stretch reflex. This figure shows the tracts we're talking about and their input to gamma motor neurons. So starting up here in the motor cortex, and note we're looking at the red part of this. note some of it is in the motor cortex, but some in the premotor area as well. And I had mentioned that earlier. But anyway, it originates in the motor cortex and or the premotor, and comes on down through the, well, you could guess it, internal capsule and the midbrain, and starts to form synapses with neurons that are in the reticular formation. Now here's the pons, here's the medulla. So this green neuron represents the neurons that are going to give rise to the, here it is, medial reticulospinal tract. Here, there will be responsibility for ultimately generating EPSPs. This little representation here of a synapse between a reticulospinal neuron and a neuron that will be found in the medial reticulospinal tract, this generates EPSPs. In other words, you have to turn this on to get it to do what it does. And what it does is generate EPSPs down here on this neuron. Okay, now we'll get to that in a minute. But you turn the system on for generating EPSPs with EPSPs. That kind of makes sense. I think it's intuitive. Down here in the medulla, this reticulospinal neuron synapsing upon a neuron that is going to be found in the lateral reticulospinal tract and has its cell body in the medullary reticular formation. You need an EPSP here in order to get this what it does. This neuron that's blue and it's going to be in the lateral reticulospinal tract. What does it do? Well, it comes down here and basically through an interneuron, it has a inhibitory effect. It has an inhibitory effect on this gamma motor neuron. They don't show the minus here. They should. That's what this does. This, in other words, this is representing a little system of interneurons that only generate IPSPs. So there'd be an IPSP on an alpha motor neuron and an IPSP on this gamma motor neuron. Whereas this interneuron that is being activated by a neuron of the medial reticulospinal tract, this would be EPSPs here, this interneuron is capable of generating only EPSPs. Here they show the plus, here they don't show the plus, but they should, to show that this whole system of a green neuron and an interneuron in the spinal cord only results in EPSPs. Okay, so let's see what we've got here. We have shown the cortical spinal tract in red, input to the pontine and medullary reticular formation. We've illustrated the input of the medial reticulospinal and lateral spinal reticulospinal neurons to the gamma motor neuron. I note that it's rather poorly illustrated, as we discussed. They should show a negative here and a negative here, plus here and a plus here, but they, for whatever reason, didn't do that. And that was the clearest representation I could find, by the way. It's not in your text, well, otherwise I would have put a figure number. And one is inhibitory, one is excitatory. And these two sources balance to set the thermostat for muscle tone. In other words, you get variable activity here and here coming down here to ultimately turn this whole system up a little bit, generating more muscle tone and more active stretch reflexes, or to tone it down a little bit. All right. Now, let me go back one. There's something obviously going on down here that we need to talk about, because this is not going to be making much sense at this point. And so that's what the next several slides are going to be about. Hopefully this is making some sense, that you've got this system of reticulospinal neurons that are going to, I should say, cortical reticular neurons from the cortex to the reticular formation that are all going to generate EPSPs down here. And you've got a system of neurons that are going to be found in the medial reticulospinal tract and the lateral reticulospinal tract. One is excitatory, one is ultimately inhibitory. Now we're going to turn our attention down to here, to what's going on here. All right. So the previous slide shows the anatomy of the system of the cortical reticular connections at the brainstem level. It also shows the input to the gamma motor neuron from the lateral and medial cortical spinal tracts. The next several slides are going to show the anatomy of what's called a muscle spindle, which I haven't mentioned before, so it should not sound familiar. And also the 2-neuron reflex arc in the ventral horn of the cord. I mentioned that there was a 2-neuron reflex arc, and we're going to look at in some detail at that. And then we will connect the reflex arc with the brainstem via the lateral and medial reticulospinal tracts. Hopefully that it all kind of comes together. All right, so this is a depiction of some muscle fibers. And it turns out that the muscle fibers are a little more complex than what we generally would think about when we think about muscle fibers. We just think about fibers that are capable of contracting, and they get input from some neurons and they contract a little bit or a whole lot. And that's sort of the end of our understanding of that. Well, to start with, there are 2 types of muscle fibers. Now, there's more than that, but for the purpose of our discussion of the stretch reflex, there are 2 types: extrafusal muscle fibers and intrafusal muscle fibers. And let's just look at the extrafusal muscle fibers right now. That's what you generally think of when you're thinking of muscle fibers, is what's called extrafusal muscle fibers. And here they are. Okay, so they may not necessarily look like ordinary muscle fibers, but they are. And we see those striations, which are the things that slide together and cause the muscle to contract. So of course, there's a whole physiology to that, but we're not going to get into that. It's not really going to help us understand SLP diagnoses anymore. So the extrafusal muscle fibers are shown at the right and left of this image, and they account for most of the tissue that is skeletal muscle. They do the work. When they contract, you actually move your body and lift a weight or do whatever you're going to do. Scattered among those extrafusal muscle fibers are these structures, and they are called muscle spindles. Now, it shows it really big here, but they're actually much smaller than extrafusal muscle fibers and just simply scattered among the extrafusal muscle fibers. And we're going to understand those at a more detailed level, because those are very important in the regulation of muscle tone and the stretch reflex, these muscle spindles. So this whole thing is a muscle spindle, and it's got some different parts. Now we're going to look at the different parts. The muscle spindles are made up of intrafusal muscle fibers. So here are the intrafusal muscle fibers, and they are on the ends of the 2 ends of the muscle spindle. Okay, so down here again, wherever you see the striations, those are the intrafusal muscle fibers. Differentiate them from the extrafusal muscle fibers, which really do the work of the muscle in terms of moving the body. Intrafusal muscle fibers are here, and they're much smaller, but they also can contract. And it's understanding that contraction is going to be an important part of it. It does have contractile properties, but cannot actually bring the ends of the muscle spindle closer together. Now, what do I mean by that? This muscle spindle, and this illustration does not show it very clearly, but you could, for all intents and purposes, just consider this to be the end, and it's attached to the extrafusal muscle fibers. Up here, it's attached. So this is a little weak structure. This is the extrafusal muscle fibers that actually make up the whole muscle are big, strong structures. These, by contracting here, you can't get this end closer to that end because it's attached to this. Does that make sense? This is attached to the extrafusal muscle fiber up here. This is attached down here. And so when you contract, you can't bring this end closer to that end. So what's going to happen? The middle part, which does not have contractile properties or capacity, will get stretched. You contract an intrafusal muscle fiber on both ends. You're going to stretch the middle part. This, okay? So the intrafusal muscle fibers have contractile properties, but they cannot bring the ends of the muscle spindle closer together. Gamma motor neuron provides input to the intrafusal muscle fiber. Now that's a key point. So what kind of a neuron and what system is going to give instructions to intrafusal muscle fibers to contract? Gamma motor neurons. What neurons give commands to extrafusal muscle fibers to contract? Alpha motor neurons. Okay? Now, within this area of the center, which is called the nuclear bag, by the way, I don't know if I put that here. Yeah, okay. Nuclear bag region, that's the part of the muscle spindle that cannot contract, but it is stretched when the intrafusal muscle fibers contract, okay? It has some endings in it, some specialized organs to sense the stretch that occurs. They are called flower spray endings and annulospiral endings. And you see this annulospiral and flower spray. So they're going to detect what's going on. They're afferent. They're going to detect what's going on in that muscle spindle and send the information back along with other afferent neurons through a spinal nerve and through a dorsal root, they're afferent, and then they're going to synapse someplace and cause some things to happen. So when there's contraction of the intrafusal muscle fiber, there's a stretching of the skeletal muscle itself. Now, what do I mean by that? Remember, this is attached here, this is attached here. If you stretch the extrafusal muscle fiber, there's going to be stretching here and activity in these afferents that go back to the spinal cord. Why would that be? Well, for example, let's take the example of the stretch reflex that's generated by the tap of the hammer on the patellar muscle within the knee. That hammer hits this and it stretches it. Now, it stretches it such a small amount, you think, well, how can that do anything? But it does. It stretches it, and in turn, it stretches this nuclear bag region and the two kinds of endings that are in it. And you start generating action potentials, which go back through those afferent. They have named them here, but we're not going to get into that level of detail. Type 1 afferent fiber and a type 1A afferent fiber. Let's just say afferent fibers from the nuclear bag region, and they go back in response to what? Stretching through by tapping a hammer on this. Another thing, another way it gets stretched, just in terms of every single movement we make, is you're going to pick up any load and you're going to send a command down to the muscle to move through these certain points to bring the water glass to your mouth. And meanwhile, as soon as you start, you encounter a weight. And that has the effect of stretching the muscle. It's so microscopic and we do it so automatically, it's kind of hard to imagine. But if you just think about it, you can imagine you're going to start to pick up a load and there is a weight. And that weight is going to be experienced by the muscle as stretch. Microscopic amount of stretch, yes, it's very small, but it's experienced by stretch. And that stretch is then picked up by the receptors in this nuclear bag of the muscle spindle, and action potentials will be sent back to the cord via those afferent fibers. And type 1A, type 2 afferent fibers go back to where? The alpha motor neuron. They go back to the alpha motor neuron. Now we'll look at, I know 1 or 2 slides, we'll see the actual circuitry of that connection. But for now, where are these going? They're going to an alpha motor neuron. And what they're going to do is pump some activity into that alpha motor neuron to say, hey, we've encountered a weight, overcome it by contracting a little harder. All right. Here we have, let's see. Let me pause that for one moment to review this. I want to make sure I got it right. Okay, I'm back. Sorry about that. When I saw that slide, I knew I needed to review it just to make sure I'm going to do this right. All right, so what we have here is we have pretty much a representation. Let me make that big so I can have my cursor proper. This is what we saw in the previous slide. Essentially, you see extrafusal muscle fibers, and you see two extrafusal muscle fibers, and then a muscle spindle, and you see the afferents represented here. And so what they're trying to do is to show what happens when that muscle, the extrafusal muscle fibers, which make up the muscle as a whole, what happens when they encounter a weight? Well, they get stretched. You see the arrows showing stretching toward this direction, stretching toward this direction because they encountered a weight. You can get the same thing by tapping at a hammer, but let's talk about a real life movement because that's the way this thing is set up. And when you get that stretch by encountering the weight that every muscle encounters in every single movement it makes, you get activity here in these afferent neurons that go back and synapse on this neuron. Now, what is that neuron? It's an alpha motor neuron. Note where it goes. It goes back to the extrafusal muscle fibers to cause the muscle that we have a name for, and we have an origin and insertion, that muscle, to cause it to move its origin closer to the insertion. You see the arrows? We're going this way and this way to shorten the muscle. And what's happening? It got stretched a little bit by the weight, and it put a little more force into the contraction to completely compensate for that. So again, it's going up. This whole thing is taking place through this 2 neuron chain to at the level of the spinal cord and at the brainstem, because you're doing this for your cranial nerves too, the motor cranial nerves. At the level of a reflex, you adjust for the weight that actually is encountered in each and every movement. That's taking place in articulation as well. So as we discussed, you have in mind certain points of placement that you need to get the articulators to for each phoneme. And then you have the reality of the phonetic context that a particular phoneme is. The amount of force that's generated for contraction has to be adjusted for the phonetic context of the target. Make sense? Again, we do it so automatically, and the amount of contractile differences seems so minuscule that you don't think we exactly really need a whole system set up to do that. But in fact, we do. If we didn't have that, all of that adjustment would have to take place at the level of the motor cortex where the commands are initiated. And all of that information about the reality of the forces applied to the muscles would have to get all the way back there, be processed in some way, and then all the way back down, make an adjustment. And there'd be a lot of traveling involved for action potentials in neurons to really make the movements we want to make. This all takes place at the 2 neuron chain down at the level where the muscle is, in the cord or the brainstem. So basically, this now shows what I just said. Assume that the system is at rest with a certain amount of skeletal muscle tone. Now assume that the skeletal muscle encounters a load that results in some stretch. The stretch causes activity in the nuclear bag here, and the afferent neuron here. The afferent neuron generates EPSPs here on an alpha motor neuron going to a skeletal muscle, i.e. the extrafusal muscle fibers of the skeletal muscle, to cause a correction for the stretch that occurred. What stretch? A stretch that's encountered in every movement we make. Forces of gravity, weight, whatever it is, inertia, co-articulation, the phonetic environment. And this pushes down the correction for variable loads that are encountered in every movement to the reflex level. And it happens very fast, of course, it's here to here, as opposed to from here all the way up to the brain, make some correction all the way back down, see? So that is what happens. This pushes down, I didn't mean to do that. This pushes down the correction for variable loads to the reflex level done at the level of, well, the alpha motor neuron, but you can begin to see why that's also called the final common pathway. In other words, there's more input to this alpha motor neuron than just a cortical spinal neuron. Remember, we started talking about the cortical spinal neuron first, part of the pyramidal system and responsible for our voluntary movements. But now we see there's more input to this alpha motor neuron. It is the final common pathway. This is, I kind of already talked about this. And what does the myotactic or stretch reflex accomplish in everyday situations? Imagine picking up a glass of water. The amount of contraction of all the muscles involved must be precise. They have to be exactly what's needed to move that glass with that weight, with that water, through the target trajectory. The cortical spinal or cortical bulbar neurons send down commands to lower motor neurons to achieve a target amount of contraction. But how much force of contraction is required to move through those target points in space is adjusted automatically by the stretch reflex or myotactic reflex. So that's what it does in everyday life. That's an accounting of how it serves us. We haven't gotten to how it's affected by various injuries, but we will get there. The clinical effects on muscle tone generated by upper versus lower motor neurons injury is this. Lower motor neuron injury is kind of simple. I think you'll find it simple. Injury to the lower motor neuron results in weakness. Okay, that makes sense. Flaccidity. Now, flaccidity is what is meant by reduction in tone. You can be a little bit flaccid or you can be completely flaccid. If it's completely flaccid, there's no muscle tone. It's completely floppy. You could take a flaccid limb and go like that. See, I'm moving it with this arm, not with this arm because this is paralyzed, but I can go like that because it's flaccid. If it's spastic, what's going to happen with upper motor neuron injuries? First of all, it's not going to be in this posture. It's going to be something like this. The most typical kind of upper motor neuron injury with spastic paralysis that we're going to see so many times have actually the nails cutting into the palm. They have to actually do something about this in terms of surgery to reduce this in the most severe cases because the nails cut into the palms. You can't even open the hand to clean it. So they're like this. And then this is flexed. So you see everything's flexed, then this is flexed and it's held in here like this. So you cannot shake. This is not going to go like this. Both are paralyzed. This is flaccid. This is spastic. So we have lower motor neurons that result in flaccid weakness or flaccid paralysis. And in combination with that, there is muscle atrophy, which means wasting of the muscle. The idea is without input from an alpha motor neuron, even if it's not doing anything, it maintains a certain degree of mass in the muscle. If you snip the lower motor neuron with its alpha motor neuron, the muscle wastes away. It doesn't become nothing, but it becomes much smaller, and you can see the difference. A flaccid muscle is a muscle that's atrophied. It's gotten much smaller. If you look at the tongue, and you have a flaccid paralysis at the right side of the tongue, the right side of the tongue looks kind of wasted away. It's smaller. You can easily identify it. If you have a spastic paralysis of the right side of the tongue is a little bit smaller, barely perceptible, but not much. And it can be equally paralyzed, but it's a different kind of paralysis. So injury to upper motor neurons results in weakness, same thing. Some degree of spasticity, depending upon exactly where the injury is in the brainstem or the cord, and less muscle atrophy. So that's how we're going to be able to tell the difference. There are other ways too, but those are key things that will help you to discern the difference between upper and lower motor injuries. All right. Other clinical signs of cortical spinal injury are these various kinds of signs, and I'm going to show examples of them. One is called the Babinski sign. Now, In the Babinski sign, it's elicited with a stimulus of strong scratching on the sole of the feet, excuse me. And the normal response is to withdraw the foot slightly, and there's a downward curling of the toes. Elicit this on somebody you know. You have to know them pretty well, I guess, and see what happens. And that's going to be a normal kind of response to that scraping. And you'll see the exact stimulus in a moment in a little video I've got. In the Babinski sign, there is withdrawal of the foot slightly, and the big toe turns upward, and the other toes fan. Let's look. I think we might have to look at a commercial first. Let's see. Yes, we do. I'll skip it as soon as I can. Okay, now here's the stimulus.
With this patient, their patient suffered
I'll
a left side of the stroke affecting the left side of the brain. The stimulus is applied to the lateral aspect of the foot and then across the balls of the toes. The Babinski response, if present, the great toe will flex and the small toes will fan out. Which is exactly what happened here.
Yeah.
One more time. Let me say the Babinski response is present. Now that with the normal sign, a similar stimulus is applied, lateral aspect of the foot and across the toes. And the great toes and the small toes flex. Extend rather, downward. So again, lateral stimulus across the balls of the toes go down. So this is Babinski response absent on a normal sign.
Okay, so that patient had left brain injury and a Babinski sign on the right foot.
Hi, my name is Paul, and this is Alice.
Because I don't think that's the one we're going to see next. That's just another example. But if you want to see more examples, obviously you can. Okay, we're going to go now back here, stop share, and come back to my screen. All right, now we're going to look at clonus, which is an extended period of jerks that occurs when a muscle is stretched. And stretching of the Achilles tendon puts the ankle and calf into a period of sustained jerks. That's called clonus. And here is an example. And these are, again, both of them are signs of upper motor neuron injury.
This video will introduce you to clonus. Clonus is something that is seen in upper motor neuron lesions during spasticity of muscles and spasticity of nerves. To perform a clonus test, you want to support the distal end of the lower extremity of the patient, and with your other hand, you want to forcibly dorsiflex the patient's foot, like so. During an upper motor neuron lesion, in what's called clonus, the patient's foot will then plantar flex uncontrollably, almost in a tremor state, for so many seconds. You want to note if it's there and how many seconds it occurs in your SOAP note.
All right, there we go. Come back here to, let's see. I don't know if I'm going through too many steps here. I may be to continue on through a list of additional ones. Now, who tests these? Neurologists. Generally, I don't even see, the primary physician wouldn't test it. It'd be the neurologist. But you will read in their notes patients' Babinski signs and clonus, and those are all signs of upper motor neuron injury. We don't test them in SLP, but I want you to know what they are. Okay, let's see. Yeah, there we go. Now, turning to something else where we're not going to do quite as much detail as circuitry. Let's talk about the basal ganglia. And you already know the components. We went through this, the caudate nucleus, the putamen, and the globus pallidus. And there is an interplay of inhibition and excitation within the basal ganglia and their connections with other parts of the brain. These are the disorders that are associated with basal gangliar lesions. And there is something called akinesia, which is a paucity of movement. They're calling it a poverty or a paucity of movement. There's also muscular rigidity. There's difficulty with initiating movement. And the most common one, and if you work in healthcare, you will see it by far, of all the movement disorders, other than paresis or paralysis, this would be the most common one, would be Parkinson's disease. And in just a moment, we'll see the resting membrane that's characteristic of Parkinson's disease. You also will see dyskinesia in basal gangliar disorders, and those are excessive involuntary movements. And examples are tremors. Now, here's a resting tremor in Parkinson's disease. And I picked this one, we could look at a bunch of tremors, but I picked this one because you're going to see it a lot.
Resting tremor consists of rapid involuntary movements of agonist and antagonist. In the following video, you are about to see a patient with Parkinson's disease with tremor in his both upper extremities. The tremor in Parkinsonism is characteristically present at rest and ameliorated during initiation of purposeful movements. Here we see the tremors of both hands ameliorated during purposeful movement and recurrence of tremor after the hand rests on the knee. This is the classic rest tremor of Parkinson's disease.
Okay, good enough on that one. And I'm going to share the screen again. Moving on. All right, so you're beginning to see that there's a variety of things. Some of them are going to be quite common for us. Parkinson's will, and the resting membrane will, but some of them not as much. These are dyskinesias. They're chorea. You might have heard of Huntington's chorea, athetosis, dystonia, myoclonus, and facial and tardive dyskinesia. They're not going to ever, none of these are going to be very common for us. I've seen probably out of 50,000 patients, 10 maybe who have dystonia or facial dyskinesia, all involving their speech. You can have dystonia in other parts of the body, but you can have dystonia that just involves here. And the most common cause, and I think probably for 10 or whatever number of patients I saw, it was always caused by a psychotropic medication, a very strong tranquilizer for something like schizophrenia. I believe most of them have a side effect, which hopefully is low frequency, of causing sort of out of the blue, these dyskinesias. And if it's focused up around here, of course, it affects speech. Typically what they'll do is take the patient off the medicine right away, and typically that helps. I mean, it can completely go away, and it can go away rather quickly. Not always, on the other hand. Sometimes it stays, and those are, very unfortunate situations. As an SLP in healthcare, you probably won't see many of these. If over a career, you will. But if you were to work in a movement disorders clinic in a medical school, so UCL has a movement disorders clinic, you see a lot of them. Why would an SLP there? Well, because a lot of them have dysarthria. This would be a what's called a hyperkinetic dysarthria, and they'll have slightly different qualities from one from the other. But I'm going to leave it to you to just look at these. It's not the sort of thing I'm going to test you on. I'm going to show you one and ask you if this is a chorea or an athetosis. We will get to the dysarthrias, and you'll be able to differentially diagnose the main ones by listening. But right now we're not going there, and these aren't great examples of that anyway. But it will show you the chorea type of movements, athetosis type of movements, and dystonias, etc. All right. Now we turn to the cerebellum. In terms of the anatomy of the cerebellum, which does our coordinating for us, there is input from the body via the inferior cerebellar peduncle. I'm not going to show the pictures on that because we're not going to analyze it at that level, but you have 3 connectors between the brainstem and the cerebellum on each side. The most caudal is called the inferior cerebellar peduncle. The middle one is the middle cerebellar peduncle, and the most rostral is the superior cerebellar peduncle. And the body needs to get input as to what's really going on to the cerebellum. And that comes through the inferior cerebellar peduncle. It also, the cerebellum also needs to get input as to what those commands are that are going through the pyramidal tract. In other words, in order to coordinate the movements, it needs to know what the movements are supposed to be. So it receives that input from the motor cortex via the middle cerebellar peduncle. And then it has to send some output. Obviously, it needs to know what's happening in the body, what the commands are, and then it needs to do its coordinating and have some input. And the output is to the thalamus and the red nucleus via the superior cerebellar peduncles. And then those project downward and do the coordinating. So again, without having to go all the way up to the cortex to coordinate movements, the interplay between agonists and antagonists and through all of your muscles involved in a movement is coordinated, smoothed out by the cerebellum in a bunch of circuitry that has been pushed down lower into the system so that it happens more quickly. The disorder that occurs, excuse me, I didn't mean to do that. The disorder that occurs in cerebellar lesions is called ataxia. And there's an example there. You can see it's just uncoordinated. People, if they have drunk too much alcohol, they have ataxia during the time they're under the influence. You know, this movement to the nose looks like this. They're having trouble coordinating agonist and antagonistic movements in a smooth way to get there. So that is something you can take a look to. And now we are through. We're to the questions. So what we're going to do when we come to the module that for number 6, you will have studied it. We'll go through the questions first. So it'd be nice for you to go through and see if you can answer these at this point. I'll have a worksheet for you as usual. I'll answer your questions as usual, and then we'll go through the worksheet problems. But that brings us to the end of the motor, and pretty much you know mostly what you need to know about the motor system, at least in the overall sense. We'll look at a little more detail at the cranial nerves as we go through them, so that you understand more about, you know, tongue movement and velar movement. But you know the principles, and especially, I would say everything that we're going to know as SLPs about the central connections with all of our lower motor neurons that are involved in speech production. All right, I will close this out at that point, stop sharing, and turn off the video, and I will see you later.